a grade 3 pyrophosphate scan. And then I was at Johnny and
Good morning, everyone. I want to welcome you to Updates in Amyloidosis 2026. I'm Sandesh Dev from Arizona State University and Southern Arizona VA. This educational activity is sponsored in part by AstraZeneca, Alnylam, and BridgeBio, which are ineligible companies. And this presentation, this conference was developed independently. I have some personal disclosures above, and the contents do not represent the views of the Department of Veteran Affairs. I want to thank our steering committee, Dr. Amber Andrade, Dr. Chris Vijay, Dr. Michael Castro, Dr. Janice Guzman, Ms. April Johnson, Dr. Indrajit Baraj, and Ms. Renee Hearns. This was also supported by Complex Adaptive Systems, which gave inspiration to us to create this event. I want to thank all of our faculty and moderators, many of whom traveled from both within Arizona as well as across the United States. We have presenters from Rochester, Minnesota, Raleigh, North Carolina, Cleveland, Ohio, Southern California, Yuma, and Sierra Vista, for example. I also want to thank our enterprise technology team. I want to thank all of our sponsors, AstraZeneca, Alnylam, and BridgeBio, as well as our exhibitors. Without their support, this event could not be possible. This event was endorsed by the Heart Failure Society of America. And I want to just give you a little bit of a flavor of the beginning of this conference starting in 2023. And we're now going to 2024, 25, and several debates in the interim. And this is our fourth year. New for 2026, we had a great case presentation last night. We have oral abstracts this year. We have a patient support group. We have a community cardiologist panel. And we have new topics covering AI, shared decision-making, biomarkers, and registry development. We'll have a debate at the end of the day. And we have interactive breakout sessions where we hope you can all interact directly with the speakers. As far as the program, some of the highlights for patients and caregivers this year are the upcoming talks by Mr. Sean Riley, Ms. Kaye Gooch, Dr. Geoffrey Jao. Also want to draw your attention to the breakout neurologic manifestations later in the morning. And then we have the panel discussion with the community cardiologist. I also want to draw your attention to the support group after lunch, as well as the session with Dr. Agrawal on shared decision making. So thank you again for coming. We have an audience of clinicians, patients, industry, and researchers. So thank you for everything you've done to make this event possible and all the work that went into this. So enjoy the conference. I want to introduce Dr. Janice Guzman.
You may have to take a walk, but different. You can tell. So my name is Janice Guzman. Again, I'm a nurse practitioner in nurse sciences from Tucson. Welcome. Glad to have you guys here. I'm part of the steering committee. I'll be moderating this session with Dr. Underwood.
So, hi, I'm Paul Underwood. I'm a cardiologist that's local here to the meetings, and I certainly thank Dr. Dev for inviting me to help moderate with Dennis. So, this will be a very lively session, and I really like the way that it's designed. It'll be from symptoms to diagnosis and treatment, and it's a patient's journey with amyloidosis. So, we'll start with the patient's perspective, certainly, and then understand what support groups are available for people who may have amyloidosis. We'll get some insights into some diagnostic pearls and tips and with the diagnostic algorithm. and then we'll understand the therapeutic landscape of the clinical trials. And at the end, we'll have an opportunity for discussion. So certainly there's something there that should touch anyone who's in the seats there, and we look forward to a very, very exciting session.
Now I'm going to go over the bios real quickly in order of presentation. So first we have Mr. Sean Riley, who is a retired nuclear reactor operations training instructor, a professor of nuclear engineering technology. He was diagnosed with a rare disease, hereditary amyloidosis, in March of 2019 and began treatment immediately. In his own words, although this can be a devastating disease, I felt such a great sense of relief upon finally being diagnosed after a 7-year journey of worsening symptoms and multiple failed attempts to arrive at a diagnosis. A pathway that unfortunately a lot of patients go through. And so we look forward to hearing your story. Sean also volunteers as a speaker for the Amyloidosis Speakers Bureau at ASHA. We got him today, so thank you for being here. Next, we have Ms. Kaye Gooch from the Amyloidosis Research Consortium. Kaye holds a master's degree in social work and has more than 30 years of experience in nonprofit leadership. In her previous roles, she led nationwide teams dedicated to the proactive and strategic development of relationships with healthcare providers. She also has extensive experience in designing and implementing programs that support individuals living with chronic diseases. At ARC, Kaye serves as the leader of the Community Alliances and Stakeholder Engagement Department, where she oversees patient support and education initiatives, as well as healthcare provider outreach and engagement efforts. Welcome. And then we have Dr. Geoffrey Jao from Honor Health. Dr. Jao is a cardiovascular disease specialist with subspecialty in advanced heart failure and transplant cardiology. His areas of focus include the management of end-stage heart failure, heart transplantation, infiltrative and hypertrophic cardiomyopathy, mechanical circulatory support, and cardiogenic shocks, cardiac transplantation, and cardiac amyloidosis. He believes the secret to providing excellent patient care is by truly caring for his patients. Dr. Jao is also fluent in Mandarin and Tagalog. I should probably practice my Tagalog with you later. It'll be fun. All right, and then finally, but not least, Dr. Lily Stearns from Cedars-Sinai is a cardiologist with additional expertise in advanced heart disease and transplantation. Dr. Stearns graduated from the University of California, Los Angeles, go Bruins, with a Bachelor of Science in Psychobiology. She obtained her medical degree at the University of California, San Francisco, and completed her residency in internal medicine. She subsequently completed fellowships in cardiovascular disease as well as advanced heart failure and transplantation at Cedars-Sinai Medical Center. So welcome to everyone. And now I hand the mic or the stage to Sean Riley.
Hello, everybody. I'm very pleased to be here for several reasons. The first reason, I want you to know that those of you who are here are physicians in the medical community, those of you who are here with the pharmaceutical companies, the support groups and all, I want you to know that what you do saves lives. And my story, I hope, is going to illustrate a success story in relation to that. The second thing is the saving lives requires collaboration between doctors and all these groups. So I'm very excited to see this collaborative effort today. The third reason why I'm excited to be here is we come from New Hampshire. It was -7 degrees this morning, so I'm not sure if I'm going back there. So I'm pleased to be here. So my name is Sean Riley. I'm a speaker for the Amyloidosis Speakers Bureau, which is part of the nonprofit called Mackenzie's Mission. We have a table set up outside if you want to come visit. So I have a 14-year story to tell, and I have 10 minutes to tell it. So hang on to your seats. I have hereditary amyloidosis, the T60, T80 mutation, which tends to be specific to people of Irish lineage. Name's Sean Riley, so you can kind of connect the dots on that one. I was diagnosed in 2019 by Dr. Rodney Fall at the Brigham and Women's Hospital in Boston. That was after a 6 to 7 year torturous journey of trying to find answers. So I'll start at the very beginning. I was about 48 years old, and I started experiencing carpal tunnel syndrome in both hands, bilateral carpal tunnel, as well as a condition called trigger finger in 3 of my fingers. Had the surgeries done, didn't think much of it. I was a very kind of a physical, athletic person, if you will, played ice hockey, used my hands a lot for doing projects around the house. So I just figured, carpal tunnel is carpal tunnel. Little did I know, and little did the physician know at the time, that was the first symptoms building in that I could notice for this disease. So this first part of the story, by the way, all happens at a local hospital up in New Hampshire. About the same time as that, in parallel with that, I started experiencing numbness in my left foot. I had previously had vascular surgery on that leg, so I thought it was maybe nerve damage from the incision they had made down the ankle. But that numbness soon began to travel, and it is now all the way up both legs into my hips, and up from my fingertips all the way up past my elbows. So it was the peripheral neuropathy building in from the disease. So fast forward from those events about a year or so, I started experiencing gastrointestinal issues, symptoms that looked like acid reflux, and then shortly thereafter I started experiencing symptoms of feeling full when I eat really early, nausea, alternating bouts of constipation and diarrhea. So same thing at this local hospital in New Hampshire. Gastroenterologist performed an endoscopy and a colonoscopy, got the results back. They didn't see anything. We now know had they taken a tissue sample, they likely would have found amyloid built up in the tissues or the nerves that make that GI system work. Fast forward about a year from that, I was sitting at home working at my desk. I stood up, I started feeling an uneasiness in my chest. I thought I was having a heart attack. I was taken to the hospital by ambulance, same hospital again in New Hampshire. They did all the workups you would do for someone coming in with a potential cardiac event, blood work, EKG and whatnot, and it all came back negative. They couldn't see any type of acute cardiac event. Same theme, little did I know and little did the doctor know then, but what I actually was experiencing was an acute bout of orthostatic hypertension, low blood pressure. So that was, had they known, that was an indicator that the autoneuropathic symptoms of the disease were starting to manifest themselves. So with that acid reflux and the GI problems, I'm not sure, but I think that's probably the sole thing that triggered. I lost about 60 to 70 pounds over about a 3-year period. Fast forward a few years after that, I had a second event. This time I was teaching at work. Same thing, I started feeling an uneasiness in my chest. They brought me to that same local hospital, did all the blood work and whatnot, no heart attack. This time the cardiologist at that hospital decided to do some tests, so they did a scan of my heart and also an angiogram. He got the results back, and he told me, he said, "Sean, I'm looking at the results, and you actually have a robust heart. It looks like an athlete's heart." And he knew that I had been previously an athletic person, and he said, "If I were you, I'd go home and train for the Boston Marathon." And I'm glad that I didn't heed his advice. Fortunately, I was athletic, but I also can be lazy. So I didn't do that. And what he was actually seeing, we know now, is an enlargement of particularly the left ventricle of my heart from the amyloid fibrils building up in the heart. So those events happened about over a 5 or 6 year period, all while I was living in New Hampshire. I can tell you that I saw a multitude of doctors throughout that, and this is kind of one of the low points of my story. Don't worry, it turns out a success story. But and this is common from what I hear with other amyloidosis patients as well as patients with other rare diseases. They get dismissed. People don't believe them. It was suggested to me that perhaps this was all in my head. I knew that it wasn't. Again, I was a rugged person. I'm in my early to mid 50s, and I felt like I was 80 years old. So it was even suggested to me, like I said, in my head, and I even got to the point where my primary care physician lined me up for it, and I started seeing a sociologist or a psychologist, if you will, for perhaps it was a mental issue with that, which it wasn't. And again, this is a common thing that we hear. So now fast forward to the year 2018. I've been working at my job for 30 years. They offered me an early retirement package. They like to kick the old people out and bring new people in. So I took them up on that offer, and parallel with that, lo and behold, a talent headhunter in the industry found out that I was available. They offered me a chance to do consulting work over in Abu Dhabi in the United Arab Emirates. I'd like to tell you that I went over there for professional curiosity. I'd like to tell you I went over there for a chance to see the world. It was a monetary offer I couldn't refuse. So even though I was not in the best of health, I chose to go over there. And this actually, as you'll hear in a minute, this decision saved my life. I was over in Abu Dhabi in the middle of the summer is when I first got there, and I wasn't there a week. I was walking around the condo complex that I live in, and this time, same uneasiness in my chest. This time, I went into syncope. I fainted, passed out. I was brought by ambulance to the little medical clinic in the village that I was living in. It was a pretty small, simple clinic. But that doctor got me in, did the same thing that they had done in New Hampshire, blood work and whatnot, ruled out a heart attack. And that doctor suggested to me, well, you moved here from the United States into the Mideast in the middle of summer, so you're probably dehydrated. So we hooked me up to an IV, gave me saline, and sent me on my way. A week later, exact same thing happened. Went to that clinic, saw the exact same doctor. This time he said, there might be something possibly cardiac going on here. So he set me up, and I don't know if people in this room may or may not know this, but the Cleveland Clinic has a huge facility in Abu Dhabi. So he set me up for an appointment to see a cardiologist at the Cleveland Clinic in Abu Dhabi, Dr. Salma Allaham. He's my friend to this day. Dr. Allaham got his hands on me. They did an echo on me, saw that my heart was enlarged. He saw that I had neuropathic symptoms, but he didn't know what was going on. But he sat me down and said, Sean, I don't know what's going on, but you are right. There's something going on, and I'm going to set up a team, and we're going to collaborate. And this is what I talked about earlier, collaboration. So he set up a team himself, oncology, endocrinology, neurology, and they all did their own testing and whatnot over about a 3-month period. And they marked their heads together, and lo and behold, they still didn't know what was going on. So Dr. Allaham had the presence of mind. He conversed with one of his colleagues back here at the Cleveland Clinic in the United States, and that colleague suggested, he goes, it's a long shot, but he may have this disease called amyloidosis. So Dr. Allaham ordered a PYP scan, a heart scan I had over there. As you probably heard, my background, I'm in nuclear engineering, so I know that scan uses technetium, and its half-life is 6.2 hours. But anyway, they did that scan, and it came back, and it showed uptake in my heart. So Dr. Allaham set up an appointment with me to describe what was going on. He explained to me that they did not have the intellectual resources over there. They weren't an amyloidosis center, nor did they have access to the new meds that were just coming out to treat me. So he suggested that I fly back. He knew I was from Boston. He suggested that I fly home and see Dr. Rodney Falk at the Brigham and Women's Hospital. So that's what I did. I saw Dr. Falk in late February of 2017. Couldn't have fallen into better hands. Some of the physicians in this room may have at the very least heard his name, but he's one of the early amyloidosis gurus, if you will. So Dr. Falk repeated all the tests did blood work, but ruled out light chain amyloidosis. They said, I'm pretty sure that you've got either wild type or hereditary. They did a DNA test, the results came back and showed that I had the T60, now called T80, Irish variant, which I call luck of the Irish. So he explained to me the gravity of the situation, and he also explained to me that there was a new drug, an RNA signaling blocker that had just come out, genetic name patisiran. So he explained to me the gravity situation, and even though it was grave, and I knew that it would potentially be a fatal disease, it was a great sense of relief for me because it was an answer to all this agonizing that I had gone through over the last several years. He also explained to me that patisiran had just come out of trial, so I knew nothing of the disease, I knew nothing of the medicine, I knew it was a brand new medicine, and having a science background, I'm always, trust but verify, so I was a little bit skeptical of it. And so I asked, I said, if I don't take this medicine, what would be our other path? And he said, well, your symptoms are really winding up now, and you probably would be fatal in 2 to 3 years. So that made the decision very easy. I said, sign me up, hook me up to the IV, and let's go. So I started on patisiran in April of 2019. I stayed on it for, I think I got a total of 75 infusions. You get an infusion every 3 weeks until I swapped over to the improved version of that, patisiran. I can tell you that once I started patisiran, about 6 months into it, I started feeling better. Dr. Falk told me, well, you're not producing more amyloid, or you're drastically reducing the production of amyloid. That process is toxic, so that toxicity is kind of being buffered, if you will. So that's why we think people initially start feeling better. But also the hope was, and it has been an absolute success, that the medicine would, if not drastically slow down the disease progression, possibly halt it. And I can tell you in my own case, I feel as though the disease progression has been halted. So that was in 2019. So about a year later, I made the decision to try to resume my career. I went back to work, and my health immediately took a turn for the worse. One of the symptoms of this disease is fatigue, and you can get it sometimes without rhyme or reason. But that work was rotating shift work, plus I was a supervisor in a control room, which is a hectic job. It took its toll on me, so I realized, that I was not going to be able to, at least for that time, continue working. So that was kind of the real low point in my story. I actually, my career was my identity. So I actually got depressed up to the point where I had to seek counseling. But over time, with the help of one of my siblings and my wife, Robin, who's here today, I was able to reframe it and try to look for the positives out of a negative. And I identified 3 opportunities that this presented me with. The first opportunity, and this is the most important one, had I not had to return to the United States for treatment, I never would have met who was then my girlfriend and is now my wife, Robin. She's my foundation. She tells me, I don't do any caregiving for you. Yes, she does. She does emotional caregiving for me, and she also drags my carcass around through the airports and whatnot when I travel around the country to do my speeches. So that was the first opportunity to meet the love of my life, Robin. The second opportunity is I realized I had to reinvent myself. I certainly could no longer do the athletic things that I used to do. I was an ice hockey player, played in men's leagues, I lifted weights. So I couldn't do that, so I had to find new opportunities. So one of the things I kind of found, one day I was sitting at a table drawing, and I realized, hey, wait a minute, I have a knack for drawing and for art. So it makes sense because my uncle on my father's side was a sketch artist for Walt Disney, so evidently that trait is genetic too. So I'm now what I would call a fairly accomplished amateur artist. I also took up new opportunities such as learning how to cook. Robin can attest to the fact that I'm pretty good at it now, so and I do it all the time. And I took up gardening. We have two Great Pyrenees dogs. If you don't know what they are, they're like small polar bears. That's part of my hobby now. So, and we also travel quite a bit. So it provided me an opportunity to, on a personal level, go down some paths and explore things in my life that I maybe never would have otherwise. The third opportunity I identified with was I understood how devastating this disease was and how devastating it was to the patient community. I felt as though since I had a science, not a medical background, but a science and engineering background, perhaps I could understand the mechanics of the disease, if you will, better than the average layperson who has the disease. Combined with the fact that over my career, I had done a lot of training, been up in front of classes speaking. So I have some natural public speaking skills. It seems to run in the family. My daughter is a actual practicing professional stand-up comedian. So that runs in the family as well. So I decided that I'd want to get involved and see if I could help be part of the solution. So that's how Dr. Falk gave me some names. The first name I got was Muriel Finkel's name from the Amyloidosis support group. Got in touch with the support group, networked further, and eventually got the name of Deb Bodica, who runs Mackenzie's Mission and the Amyloidosis Speakers Bureau. So I've been a speaker now for about 4 years, and I travel all over the country talking to at med schools. So that's where I am now. And again, going back, this collaboration and everything that all of the entities do in this group, whether it be physicians, support groups, and whatnot, you're saving lives, and what you're doing, gathering here today, is so important. Thank you.
Thank you. I forgot to mention earlier, please hold your comments and questions for during the panel discussion. Okay, so next, Ms. Gooch.
Thank you. Can everybody hear me okay? Great. As mentioned earlier, I am with the Amyloidosis Research Consortium. And we were started in 2015 by Isabel Lusada, who is actually an AL patient herself. And her goal is to start this organization to be able to provide the patient voice in research and also to help extend the lives of those living with amyloidosis. I'm going to talk a little bit in my department, which is helping to support patients. We do have, just to let you know, for your patients and for you as someone who's affected by amyloidosis, that we have a licensed clinical social worker who is our patient support person. She's available to provide treatment information. She can help with referrals, resources, people dealing with financial situations. Also emotional support, because it's important when people, I heard Mariel talking about that last night, when people call and it's a lifeline to be able to talk to somebody as well. Another thing I wanted to mention is our Peer Link program, which is a peer mentoring program. So we have trained mentors who can talk to people one-on-one if someone is newly diagnosed or perhaps they're going through a difficult time. We're able to connect them to someone, and it's great as a social worker or somebody else to be able to talk to people, but there's nothing like that having an experience with another patient. So, and you can certainly learn more. Our patient support line is at support@archie.org, and also the phone number there. Just another thing, also ARC provides a variety of patient materials. We do have a table out here today, so if you'd like to take a look at some of those, we can mail them to you, or we also have those available for your clinics if you'd like that. We do a monthly webinar series that has topics of interest to people with amyloidosis. And our website is arci.org. We have a lot of information there. as well as resources for support and information for healthcare providers. If you're interested in kind of staying up to date with what's going on, we also have a monthly e-newsletter that you can sign up for that. I'm happy to talk with you about that later as well. There we go. And one other thing I wanted to mention is we have something called My Amyloidosis Pathfinder, or MAP for short. It's an online tool that can be used by patients. It has one section of it has clinical trials. So if you, as a patient, sign up, you can put in your type, any kind of organ involvement you have. And when there are new clinical trials available, we put them into the system and you will get an email just alerting you to the fact there's a new clinical trial out there in case you're interested and checking out and learning more. The other side of MAP is also the treatment center locator, so patients can go on, you pull up your state, and you can then find the different centers that are available. You can compare the centers and look at that information. So that's also on our website as well as on the front page of the website. One thing I just wanted to bring up too is we've just recently started something called Amyloidosis Project ECHO. And Project ECHO has been out there for a long time, started at the University of New Mexico. And there's a lot of other different disease states there, but this one is the first one that's specific to amyloidosis. So it's for healthcare providers. And there is a didactic at the beginning. We get people to do case studies. And then after that, there's a lot of conversations, kind of the teach all, learn all model. And so that's available. It's rotating AL and ATTR. So I do have some information on that if anyone's interested. There's, of course, the QR code to register or to find out more information, but it's held quarterly. Now I'm going to talk a little bit more today. ARC, in the past 10 years since we were founded, ARC has really conducted a number of surveys for patients and getting feedback. And each one of these studies kind of builds on the other. We have something called our community survey that we've done for probably the last, moving into the 5th year. It really helps us look at the lived patient experience for that. When we first started, we did a study in 2015, and it was on for AL patients. And one of the things that it showed was really that people were having long diagnostic delays, and they were seeing multiple doctors before they got to a correct diagnosis. But patients really said in this survey that they were very interested in taking part in research studies. So that was kind of the impetus for ARC to kind of start moving forward, and that there just wasn't a lot out there, of course, in 2015. The next thing is we did a study in 2017, a cardiac survey. And in that survey, kind of the highlight to that is that patients were still saying they were being misdiagnosed, given inappropriate medications, and it really kind of showed that need for some standard diagnostic and more modern imaging tools. And those are things that ARC has continued to focus on since that point. Also in 2018, we focused on hereditary and did a burden of illness survey and really heard from patients just how much this affects every part of their life, not only just their health, but the disease was affecting their independence, their work, and overall well-being. At that time, of course, treatment options were still very limited, yet we knew patients were willing to take on risk for just even moderate benefits. So that really kind of does underscore the need for just really more effective and tolerable treatments. So in 2021, we did an ATTR affordability study because when new treatments come along, they're expensive, and along with that comes the ability for people to have to pay for them. So we found in the study, and I'll talk a little bit more about this in another slide, but patients were really reporting financial strain, more than half of them. And that reminds us that affordability is really part of the quality of life for people. In this study in 2023 with patients, we did another one on ATTR burden. We used our ATTR quality of life questionnaire and found that fatigue, nerve pain, which Sean talked a lot about over here, and balance problems still affected daily life. And importantly, that caregivers were really experiencing a lot of stress and burden of strain. And so again, each of these surveys kind of brought that patient voice into research studies into what we were doing. This is going to be a little bit more busy here, but this kind of looks at how the landscape has changed in the last 10 years. And this is interesting to me. In the early years, wild type was barely recognized. I mean, there just wasn't, it was even kind of put under the other, so it was rarely identified. And today, of course, it's one of the most commonly reported subtypes, but then there just wasn't the awareness and testing that's available today. So you kind of take a look at how that has changed through the last 10 years. Also, this study, we looked at the patterns of how organ involvement has changed over the last 10 years. Of course, the heart remains the most commonly affected organ, which I think surprises anybody. But we're also seeing more growth in gastrointestinal symptoms and a growing number of patients with nervous system symptoms, particularly among people with wild type. And that's important because, you know, wild type and hereditary were once thought to be primarily cardiac, but patients are really reporting there's a wider systemic involvement than we previously thought. There's another busy slide for you. And this is really looking at those initial symptoms, so when somebody started having symptoms to when they were diagnosed. And of course, these studies do have different patients, so early symptoms can naturally differ here. But back in 2015, the most common symptoms that were reported were fatigue, shortness of breath, weakness, neuropathy, and swelling in the legs or the tongue. But in our more recent surveys, we're seeing, you see the last couple of years, we're seeing a shift, like carpal tunnel syndrome and neuropathy are being recognized earlier, so patients are reporting those, which is really reflecting, I think, a greater awareness and earlier diagnosis with the disease. And this is looking at like the time from the initial symptoms to the diagnosis. And so this has really evolved over the years as well. You can see going down, and we're starting to see signs that there's early recognition and earlier diagnosis and faster diagnosis. The mean time on this last one from 23 to 25, I don't have that data there now, but it's 3 years to be diagnosed. So even though that's some improvement, we still have a ways to go on that. And this is looking at the number of physicians that were visited before an establishment of the diagnosis. So for a lot of people, it takes going to see a multitude of doctors. I talked to somebody the other day, she'd been to 8 doctors to be able to get her diagnosis. So, and that just provides a lot of frustration for the patient and a lot of time. But the good news is, as you look at these slides, we're starting to see some improvement in that as awareness is spreading. And patients still have to get referred, which you talked about, Sean, but patients still have to get referred to get diagnosed, and so we want that to happen in a timely manner. So I think this is a reminder while continued education, early recognition remains so important. And then just looking at the diagnostic testing. Back in our 2017 cardiac survey, patients said that they reported needing more invasive heart biopsies to confirm their diagnosis. But you'll see here over time now, people are starting the PYP imaging And it's really showing a shift in going from having much more invasive to the non-invasive test to get diagnosed. And barriers to diagnosis, we also asked that in the community survey to see what are the most common barriers to diagnosis. And I have it broken down by hereditary and wild type. For hereditary, one of the biggest barrier was misdiagnosis. So there was about 41% of patients were misdiagnosed. About 23% had trouble with insurance. And then in wild type, it was 27% misdiagnosis and 23% had trouble with their insurance in getting tested. So this is the ATTR affordability study. I just talked about that a little bit earlier, but this is another slide. I'm sorry, it's small here, but of course, rare disease, treating rare disease is not cheap, and amyloidosis is not an exception to that. You can run from $250 to $450 a year for treatments. We showed in this study that 43% of patients said they used their savings or borrowed money, or they made trade-offs, such as not taking a vacation or selling their house to afford their treatment. And we used a tool here to measure financial strain of patients, and 55% said that they experienced some sort of financial toxicity, which is a lot. 33% of patients reported that they spend between $1,000 and $2,000 a month, with an average about $711 a month. And one of the concerns we hear from people is, they have to keep applying again for the patient assistance programs, and so there's always that level of each year the stress on whether or not this is going to continue. They're going to be able to continue taking the drugs. So this is just, there's a lot more information. I gave you just kind of a short version of what's available on our surveys. So if you are interested, you can go to our website, and there's a drop down for the community survey, and you'll be able to find more information for that. So this is just to thank you again, just to kind of show our patient support information in the website. Thank you.
Stand.
Okay, yeah.
All right. Right. Good morning, everyone. First off, I'd like to thank the organizers for the invitation to come talk to you about a topic that I'm very passionate about. This is cardiac amyloidosis. In the next 15 minutes or so, we'll be talking about some diagnostic pearls, clues, the pathways, and the pitfalls in coming up with this diagnosis of cardiac amyloidosis. I have no conflict of interest to disclose, so without much further ado, we start off. What is amyloidosis? Amyloidosis is a disease process wherein you have amyloid fibrils deposited in soft tissues, right? And when we talk about amyloid proteins, as you can see on the left column, there are plenty of them, but the good news for cardiologists is that there are just a handful that affects the heart, right? And even better news is that 2 of them affects 95 to 98% of patients with cardiac amyloidosis, and they are the AL subtype as well as the ATTR. While ATTR is by far more common than AL amyloidosis, I feel it is important and as to talk about and ruling out AL amyloidosis first when you think of this diagnosis. Why? Because as you can see on the slide, untreated cardiac AL amyloidosis carries a high probability of death, and it kills you within a short period of time. And if you can take a look at this graph, it's under 3 months, 50% survival. And the even better news is once you diagnose it, nowadays we have treatments that are effective. We transition to by far the more common cause of amyloidosis, which is the TTR subtype. TTR is produced in the liver, mostly, and some in the eyes, right? It is a tetramer molecule that eventually becomes a monomer. That monomer freaks out in a configuration that becomes very sticky. They form fibrils, and with that, they then deposit in soft tissues. Because it's in blood, it can circulate anywhere. it affects nerve tissues, et cetera, et cetera. And as you heard, it's multi-organ involvement. But why is cardiac amyloidosis important? Because as you can see, what I'd like to show you in this slide are all-cause mortality data, looking at different RCT drugs that have been shown to have survival benefit. But I'd like to have your attention on the placebo part of these graphs. What it shows is that it is a progressive disease. And the better news nowadays is that there are effective treatments that naturally changes the natural history of this disease. You will see that there are all-cause mortality improvements across the board in these three different therapeutic regimens. But, for someone who's 80, 85 years old with this diagnosis, is survival really a priority? Is that meaningful, right? It takes about 1.5 years before all-cause mortality data shows up in these studies almost uniformly. But, the better news is that whether we take a look at patient-reported wellness or objectively measure them in 6-minute walk tests, these patients feel better quickly, right? In some forms, 3 months, 6 months, and it continues. What we have to know from this slide is also diagnosis and therapy needs to be early because the therapeutic regimen seems to work best for those with early disease. Can we go back one slide, please? So here is a gross pathology slide of heart that's affected by amyloidosis, right? This is clearly advanced stage disease. This is not what we want to see by the time we diagnose them. It's way too late. Cardiac amyloidosis basically deposits an extracellular tissue of the heart, and it affects everything. The left ventricle, as you can see, is extremely thick. One forgets about the right ventricle, but the right ventricle also gets thick. The valves, the interatrial septum is thickened, and if you look closely, it affects the conduction system and even the pericardium. What we try to do diagnostically is to see these non-invasively, at least at first, right? We start with EKG, cardiac biomarkers, and then echocardiogram. And I'm not sure if you can click that, but what is on top, on the right of the screen where you see echo images, sorry, I don't have a pointer here with me, but you will see that the left ventricular walls are extremely thick on the top left corner of the echocardiogram. The atria are huge. Sometimes the LV systolic function are already weak at the time of diagnosis, and that's not good. And the bottom screen is just to highlight the fact that the right ventricle on top, the subcostal view, is also thickened. Part of what I wanted to show on this slide is that your EKG, okay, although the heart is thick, the EKG becomes smaller and smaller. And so that amyloid fibrils has an insulating effect on the EKG. So we have what we call voltage to mass disproportion. In other words, the EKG voltages are becoming smaller and smaller as the heart gets thicker and thicker. So that's discordant. Another thing that I'd like to say is that if an EKG is not necessarily small but normal and your heart is exactly so thick, that is also relatively abnormal. Next slide. Back one slide. So for the cardiologists in the room, these are some of the things that we look for. Provided you have a sinus rhythm, we look for a restrictive filling pattern, right? That is the E to A of greater than 2, and your filling pressures, your E to E prime is elevated. Letter B shows you a 5-5-5 sign, and what this basically tries to show you is that the myocardium, although thick, although the EF may be okay, actually doesn't contract very effectively. And if you take a look at the amplitude on the right screen, it stays below 5. And the apical sparing pattern that we almost always see, you can actually see morphologically on the echo, except that it's better seen on a strain image. And we take a look at the polar plot. What you will see is the cherry on the top side. right? On the middle stream where it's heavily red, that is the apex, and then the pink one is towards the base. So when you look at an echo, the heart moves on the apex the most, and then at the base the least. And lastly, although the ejection fraction may be preserved, in other words, the contractility of the heart measured by ejection fraction may be preserved over 55%, you will oftentimes find that the average global longitudinal stream is abnormal. Normal is minus 18 and less, right? And minus 7.5 in this case is extremely abnormal. So these are some of the echo findings that we have. I talk about echo because this is one of those earlier and more available diagnostic modalities that we have. I like this slide, which shows the tests on the left and at the time it becomes abnormal relative to the time of onset of TTR amyloid deposits. I'm going to start from the top, and when you say systolic dysfunction in LV is already down, that is pretty advanced disease. By the time you see EKG, low voltages, pericardial effusion, and a thick heart, that is relatively advanced disease. Symptoms precede these findings. Symptoms of heart failure, predominantly right heart failure for restrictive cardiomyopathy, should be looked at. Fatigue, shortness of breath, these are heart failure manifestations. EKG, by the way, EFib is extremely common and is present 70% of the time, so something to take a look at. Cardiac biomarkers are normal and may not be abnormal in very early disease, right? But it becomes stably elevated over time if there's disease progression. Biopsy towards the bottom is our most sensitive and specific test and can pick up very early disease. Yes, it is not always available, and part of the reason why we're diagnosing amyloidosis more is because we have this modality called technetium paraphosphate scan, wherein it is a non-invasive surrogate for a biopsy with high sensitivity and specificity, provided monoclonal gammopathy has been ruled out, right? Before the heart is ever affected, we have other organs that would have been already affected this time. And part of the reason why the diagnosis of cardiac amyloidosis is delayed is because you have a multitude of different other organs with symptoms and signs that are fairly common in older individuals, right? Older males. So when we take a look at, I'm going to leave the heart to last. When we take a look at this, back pain, knee pain, weakness, difficulty walking and falls, right? Erectile dysfunction, if you're 80 years old, who would think about cardiac amyloidosis? Part of the reason why we miss this diagnosis. And but what is something unique? By the way, unexpected weight loss, orthostatic hypotension. But when you take a look at the orthopedic manifestations, what you don't see every day is bilateral carpal tunnel, right? And if you have a ruptured distal biceps tendon, which we call the Popeye sign, you basically have a TTR, cardiac amyloidosis diagnosis, right? From the cardiac manifestations, heart failure, but with predominant right heart failure findings, you have JVD, ascites, lymphedema, in addition to breathlessness, shortness of breath, exertional dyspnea, fatigue, right? And you will find AFib. You may find AFib because this is extremely common, 70%, and bradyarrhythmias that you will see. So you may see a preserved EF with a pacemaker on someone who's old. Why is that? Right? So part of the diagnostic delay, and we see multiple doctors see the patient, is because they manifest early in the disease something that is rather non-specific, right? And then progress to cardiac symptoms, and we can say, oh, this is just bread and butter heart failure. But this is, you need to take a look at the whole picture together for us to come up with this diagnosis. So we talk about bilateral carpal tunnel. These group of investigators came together to screen for cardiac amyloidosis 5 to 15 years after their surgery for bilateral carpal tunnel. And what did they find? So what they is at the time of bilateral carpal tunnel surgery, and you find amyloid deposit in the carpal tunnel ligaments, it's about 10%. And about 2% of these have cardiac amyloidosis. So what they say is that maybe if you screen a little bit later down the road, your yield will be higher. So what did they find? 250 patients, 1-to-1, male to female. What they found was that bilateral carpal tunnel is by far more common among females than males. But amyloidosis affecting the heart is 4.8% total, and that affects more males. And when you say, just look at the males, it's 8.8%. And if you look at males over the age of 70, who has a BMI under 30, that prevalence increases to 21.2%. When comparing the echocardiographic ECG findings of patients with cardiac amyloidosis relative to those without, you will see the IV septum heart is thicker, it's heavier, it is more stiff, and it is more elevated, higher filling pressure. So the left atrium is enlarged. And when you take a look at the EKG, we talk about low voltage, but another thing to look into is Q waves in someone without regional wall motion abnormalities, and Q waves in someone who has no known obstructive coronary artery disease. We call it pseudo-infarct pattern. And I've talked a lot about voltage to mass disproportion, and there's actually a mathematical number that you can have there, but we're not going to go into that. In terms of the biochemical cardiac biomarker abnormalities, we have NT-proBNP, troponin T, and then estimated GFR, things that we use for prognostic changes, NAC score, et cetera, and of course, PYP scan. Diagnostic algorithm, and I'm going to be quick because I have 1 minute left. So once you have those clues, ECGs, echoes that make you suspect cardiac amyloidosis, the first thing that you want to do is rule out monoclonal gammopathy. One of the earliest points that I like to say is when you think about this diagnosis, you rule out AL amyloidosis first, because that is fatal left undiagnosed. You have serum kappa lambda ratio and your immunofixation, both serum and urine, and if you have to pick one or the other, you pick serum. The guidelines actually tell you that electrophoresis is not the test, right? It's not sensitive enough. And that the kappa lambda ratio is dependent on your renal function, and if your estimated GFR is less than 30, then the normal kappa lambda ratio raises from 0.26 to 1.65, and that range goes up to 0.54 up to 3.3. Okay. So once you have monoclonal gammopathy, get tissue. Okay, send them to your hematologist, to your cardiologist, endomyocardial biopsy, et cetera, and what the commentary in red says, fat pad lacks sensitivity, and that has been my experience. Once you have tissue, stain with Congo red. If it's abnormal, then you do tissue typing with mass spec, you come up with a diagnosis of AL amyloidosis, you treat ASAP. Once monoclonal gammopathy, all these tests were within normal limits, no monoclonal gammopathy identified, then the next test of choice, technetium paraphosphate scan. If you have grade 2 to 3 uptake, you clinch the diagnosis of TTR, cardiac amyloidosis, right? No other imaging modalities to date can give you that specific diagnosis, and hence that appears instead of an MRI, et cetera, et cetera. If that is negative, cardiac amyloidosis unlikely. If it is positive, then you clinch the diagnosis of ATTR, you send them for genetic testing, and you come up with either variant or hereditary cause, or that from growing old. Used to be called senile, but now we're more politically correct. We call it wild type ATTR. All right. So some things to kind of not miss. Okay. PYP scan cannot be diagnosed independently without looking for monoclonal gammopathies. Second, you want to make sure that if your clinical clue just tells you that I have pretest probability, high pretest probability, then a negative technetium paraphosphate scan should be followed by a biopsy. Technetium paraphosphate scan, what is it? What is grade 2? What is grade 3? It is a bone scan, but it's taken up in the heart. Why? I don't know. claim of no monoclonal gammopathy. There are things that can cause false positive technetium paraphosphate scans, and you need to kind of consider this in the clinical context, right? We say that the PYP scan has to be done with SPECT so that we do not create this false positive of blood pooling, right? In other words, PYP is in the blood and not in the myocardium. If you just take a look at the plain film, it can be misleading. AL amyloidosis can be positive, have a positive PYP scan in as much as 20% of cases, so must not miss monoclonal gammopathy. Hydroxychloroquine MI within 4 weeks, hyperoxaluria, breast implants, and metastatic calcification of patients with end-stage renal disease on dialysis. False negative is if the disease is very early and in rare TTR variants. Note that if you have delayed imaging, if you give the tracer and then it's more than 3 hours after, then you scan, the scan could have gone away from the heart. So, and the wrong tracer, of course. MRI, we're not going to talk about, but it is important to say that, there's abnormal T1 numbers. They are elevated. If you see no LGE in the top, it's a normal heart. Patients with cardiac amyloidosis have increased T1. There's late gadolinium enhancement in earlier disease, subendocardial, in more advanced disease, transmural. It's hard to know them. And the ECV, or extracellular volume, is extremely high. Okay, so this is just to make the point that the PYP scan, or the HMDP scan, is used nowadays in the absence of monoclonal gammopathy because its sensitivity is very high, specificity is all high. You don't need a biopsy, and it differentiates TTR from AL. Biopsy, 100% sensitivity and specificity, a low risk for complications. This is just to say that the surrogate is for FAT is quite low in sensitivity. So I'm going to end with a case. You have a 78-year-old male with a BMI 18, short of breath with exertion, AFib, has a history of bilateral carpal tunnel. You suspect cardiac amyloidosis. You get an echo, thick heart, and then abnormal EKG pattern, and then you have 5-5 sign present, polar plot present, and then you do a monoclonal test negative. You do a PYP scan, and that's your scan. You clinch the diagnosis of TTR cardiac amyloidosis. Next step, genetic tests, send to clinic, treat. Right? You don't need to have positive genetic tests before you initiate treatment. What if you have the same scenario, all these tests the same, and your PYP scan? What is the next step? Volunteers from the audience. High pretest probability, abnormal, all other tests except for the PYP scan. Next step. Biopsy. Amen. So, take-home messages. Although rare, AL amyloidosis we must not miss. Hence, it's very early on in the diagnostic algorithm. My fellow says to me, when I was giving one of these talks, it says, to diagnose TTR early, all you need is to TTRY. I love that. And we must not diagnose TTR cardiac amyloidosis just based on the PYP scan. You can miss AL cardiac amyloidosis. Always has to rule out MGUS. And lastly, the tissue settles the issue. When in doubt, and your high pretest probability, biopsy the involved organ. That's it. Thank you.
Okay, so thank you so much for having me here today. I don't know if I'll advance the slide to get this. There we go. Great. So I want to thank Dr. Dev and the organizers for inviting me here today. It is just such a pleasure to be here. And I want to thank the rest of the panel today. What an amazing way to start off the program, hearing from our patients and our incredible support groups and research groups, and then to Dr. Jao for setting me up to talk about novel therapeutics. And I'm going to focus on transthyretin amyloid cardiomyopathy. So we will not be talking about the AL treatments in the next 20 minutes. Here here are my disclosures. So I attest that this presentation is evidence-based and free of commercial bias, but I'll be talking about all the different treatments. Okay, so when I think about approaching a patient with ATTR cardiomyopathy, I think about three big buckets. I think about ATTR disease-modifying therapies, treatments that are targeted for their general cardiovascular sequelae, so heart failure treatment, arrhythmia treatment, and then end-stage cardiac treatments such as predominantly the need for heart transplantation. But I unfortunately only have time to talk about the disease-modifying therapies, but there's so much to cover here. Okay, so over the past 10 years or so, there has been an explosion of novel therapeutics in this field, and they target different points along the amyloidogenic pathway. And we're going to walk through them. And I always like to think about this analogy of, a bathtub and water filling the bathtub, where water is like the amyloid fibrils and the bathtub is the myocardium. And to treat this condition, we can either turn down or turn off the faucet, but we also need to drain the tub to get rid of the water, to get rid of the amyloid. So we currently are investigating and have treatments that silence the protein production. So that turns off the faucet. We have treatments that stabilize that homotetramer, prevent it from forming more amyloid. And then in the future, we're hopeful that we will have treatments that are ATTR-directed monoclonal antibodies that will deplete or degrade the amyloid fibrils, both the misfolded TTR that's circulating, so turning off the faucet again, but also ultimately draining the tub, actually going in, targeting the amyloid that's already been deposited, and triggering the immune system to clear it out. So as of January 2026, we have 3 FDA-approved therapies for ATTR cardiomyopathy, both wild-type and variant. We have 2 stabilizers, tafamidis and acoramidis, and 1 silencer, vutrisiran. We have other silencers that are undergoing investigation that we'll talk about. There's some novel therapeutics, including CRISPR-Cas9 technology to gene edit out the encoding for the protein. And then we have clinical trials looking into these depleter-degrader therapies. We're going to talk through about all of them. So when thinking about the natural history of ATTR cardiomyopathy, we know that this is that patients are depositing amyloid when they have this condition. It's occurring over decades. So people are depositing these amyloid fibrils in the heart over decades. Initially, they have no symptoms, and ultimately they start to develop early symptoms, and then they develop heart failure, and then ultimately, once they reach this critical burden, there's a rapid decline that can occur. And historically, we were diagnosing people when they were way late in their disease course, and you see these examples of these echocardiograms, and people are really advanced. And at this point, the water has already filled the bathtub. And we really need to be catching people earlier in the disease course because as of now, we only have treatments that turn off the faucet. So these treatments are most effective earlier in the disease course where we haven't filled the bathtub yet. We're just starting to fill it so we can just halt the disease progression. And that will be a theme as I go through the clinical trials. So we're going to start off by talking about stabilizer treatment, as these were the first FDA-approved therapies for this condition. So we have tafamidis and acoramidis, which have been FDA-approved. And so what are these treatments? So we're going to start off with tafamidis. So tafamidis is a small molecule that binds to the thyroxine or retinol binding protein site of the TTR protein. Because remember, transthyretin is a transport protein. It transports thyroxine and retinol. And it binds to those pockets. And I wish I had a pointer here, but you can see those little red molecules. That's where it binds. It's 1 pill a day, and it was studied in the pivotal ATTR-ACT trial that was published in the New England Journal of Medicine medicine in 2018 and ultimately led to the approval in 2019. And this was the first FDA-approved therapy for this condition. And I'm sorry the text is so small, but basically in the study, they looked at pooled tafamidis, 20 and 80 milligrams compared to placebo, and they found a significant favorable effect for the therapy with a win ratio of 1.7, which is a more advanced statistical method. But when thinking about kind of some more traditional statistical methods, we can see that there's about a 30% relative risk reduction in all-cause mortality, with a number needed to treat of only 7, and a 32% relative risk reduction in cardiovascular-related hospitalizations, with a number needed to treat of only 4. And we'll see this pattern, as I discussed, these therapies, they halt disease progression. They don't reverse it necessarily. And so they looked at secondary outcomes of quality of life and functional capacity metrics. So 6-minute walk test, how far can a patient walk in 6 minutes, and then the Kansas City cardiomyopathy questionnaire scores to address quality of life. And we see that there's an attenuated decline in these metrics. So we're halting disease progression. And the highest benefit is seen in those earlier stage diseases, the New York Heart Association class 1 and 2 patients. So moving on to acoramidis. So acoramidis is another small molecule, but it has a different mechanism. It mimics a stabilizing TTR variant, the T139M variant, and it's given in 2 pills twice a day. And it was studied in the phase 3 Attribute CM trial that was published in the New England Journal of Medicine in 2024, leading to its FDA approval later that year. So again, they used a similar method, the Finkelstein-Schoenfeld method, a statistical method, but they looked at 4 outcomes, composite hierarchical outcomes of death from any cause, cardiovascular-related hospitalization, NT-proBNP, which is the cardiac biomarker of stretch in the heart, and 6-minute walk distance. And they found a significant favorable benefit for acoramidis compared to placebo with a win ratio of 1.8. And then looking at kind of the more traditional metrics, and again, I apologize, this is so small on the screens, but we see about a 36% relative risk reduction in all-cause mortality or first cardiovascular hospitalization, with a number needed to treat of 7, which is similar to the ATTR trial for tafamidis. And then they also looked at cardiovascular hospitalizations and found a very impressive 50% relative risk reduction with a number needed to treat of 5. And if you look at these Kaplan-Meier curves, which are those curves in the right lower corner, the curves actually split at about 3 months. So it just really emphasizes the importance of getting patients on treatment as soon as possible, as soon as they're diagnosed with the condition. They also looked at some similar secondary endpoints, so 6-minute walk test, KCCQ scores, we saw an attenuated decline. The NT-proBNP levels also, we see an attenuated decline. And then a new variable that wasn't assessed in the ATTR trial was looking actually at TTR levels, which are prealbumin levels. So if you are patients in the room and maybe you've seen those in your labs, they're the same thing. And basically this brought up this new idea of, if you are stabilizing that homotetramer, less is going to be in the amyloid form or the misfolded form, more will be in the intact form, and you'll see higher levels in the blood. And it's created this interest that maybe TTR levels could be a biomarker that we follow for treatment response. And I know we're going to have a whole debate on this later, but I just wanted to introduce this idea and review some of the data from the clinical trials that we have. So in Attribute, they actually studied this further. We're looking at their data from the original trial over 30 months and then their open label extension where everyone switched over to acoramidis. You can see that, and just for some background, because this was this trial came after tafamidis, at a certain point tafamidis was approved. So after 12 months of being enrolled in the trial, patients were provided the opportunity to start tafamidis if they wanted to. And so they looked at only those patients who were just on acoramidis, and they found that their TTR levels rose on average by about 9 points, so 9 milligrams per deciliter by month 30. And then when they looked at the patients who were in the placebo arm who happened to start the tafamidis after those 12 months, by 30 months, they saw that their TTR levels rose by about 6 points. And then when they switched over to the open label extension, where everyone switched over to acoramidis, you can see the numbers are quite small, but you see that those patients actually went from 6 to 9. So they went up by about 3 milligrams per deciliter, so kind of catching up with where the levels were for acoramidis. And this was sustained at 6 months as well. So then this makes you think maybe TTR levels are something we should be following, and it brings up some ideas and people try to compare the trials and the different therapies, but I want to just caveat that interpretation because we don't know a lot about this. We're still understanding the mechanisms of this condition. So yes, some proposed mechanisms for increased TTR levels are, yes, we're stabilizing more TTR, and that is the goal, right? But there's some other mechanisms that may explain the rise in the TTR levels. There may be improved secretion of TTR from the liver cells, and there may be, and there is also evidence of decreased turnover of the TTR, so less lysosomal degradation. So you may just have, by giving at least these stabilizers, it may actually just raise the levels of TTR in general that require more drug for more stabilization. So we just have to interpret these results with caution because it's unclear, if they're different for different drugs. We know that, this is being studied with the acoramidis data, but we don't really have that for the tafamidis data. There may be different changes for different ATTR subtypes, wild type versus variant, and we don't know whether it's associated with differences in survival. They did look at, in the attribute cohort though, they did actually look at their patients and they looked at the change in their serum TTR levels after a month of therapy, 28 days of therapy, and they actually split up the patients into 4 different groups to see the magnitude of that change, and they found that for those who had a higher rise in their TTR levels, they actually did have improved survival over the 30-month period. And they found that for every 5 milligram per deciliter increase in the TTR levels, there was a 26% relative risk reduction in mortality. So this actually is very interesting data, but with the caveat that this was all post-hoc analysis. They weren't, this wasn't pre-specified, but it does give some support that maybe this is actually helpful, at least for acoramidis, but we don't have the data for tafamidis. Okay, so moving on, we're going to be discussing that more later today with the debate, but we're going to move on to the silencers. So the silencers are a great technology where basically we have small interfering RNAs and antisense oligonucleotides, which basically go into the hepatocytes and interfere with the transcription, the creation of the TTR protein. So we're silencing protein production. And they've been studied extensively in ATTR variant peripheral neuropathy, but have only recently, we have newer data in the cardiomyopathy space. So a lot of these therapies are approved for peripheral neuropathy, but the only one approved for cardiomyopathy, now both variant and wild type, is vutrisiran. And then these other two, eplontersen and nucresiran, are being investigated. So we're going to talk about those now. So vutrisiran was studied as a small interfering RNA. It's given every 3 months subcutaneously in a healthcare setting or at home, but administered by a healthcare provider. So it's covered under Medicare Part B rather than Part D, which is the stabilizer therapies. And it was studied in the Helios-B phase 3 clinical trial, which is the largest trial to date so far. It was published in the New England Journal of Medicine in 2024, and then ultimately FDA approved in March of last year. So these patients, it was a newer era. So in this time, there were, tafamidis was on the market. And so patients were allowed to be on tafamidis. So about 40% of patients in each arm, and they included that in the randomization, were on both tafamidis and vutrisiran. And so they looked at both the overall population, including everyone, and the monotherapy population, those just on vutrisiran and just placebo. And you can see, again, we get similar results from the prior trials, about a 30% relative risk reduction in all-cause mortality and cardiovascular hospitalization, which is an incredible result. They also looked at the secondary outcomes of quality of life and functional capacity, and we see again attenuated decline in these metrics as well as the New York Heart Association class. And then in this trial, they also looked at TTR levels, but as you can expect with the stabilizer therapies, we see those levels rise because we're stabilizing that homotetramer, but in the silencer trials, we're suppressing the TTR production. So we found an 81% reduction in the TTR levels
the 36 months
of the trial. And so there are two other silencer trials that are ongoing right now in phase 3. So we have a plantirasin and CardioTransform, which is an antisense
nucleotide given every month at home with a pen. It's almost like those GLP-1 agonists or the PCSK9 inhibitors where a patient could administer
it themselves at home. And then nucresiran, which is almost like a
third generation small interfering RNA, and it has a longer duration of action than vutrisiran. So it's given subcutaneously every 6 to 12 months. And it's being studied in the Triton CM trial. And both of these trials are going to be the largest clinical
trials to date in the TTR world. Over 1,400 patients.
You saw some of the data on the plantirasin last night, but it's going to be a really big trials. And at this point, these patients, the standard of care, what was FDA approved when patients started enrolling in the trial were the stabilizer therapies. So a big question that comes up in the therapeutics world is, hey, for heart failure with reduced ejection fraction, we have these therapies they work in synergy, right? And so could the stabilizers and silencers work together to treat this condition? If we're silencing the TTR production by 80%, there's a still residual 20% that's circulating that could be stabilized. And so the question is that actually beneficial? And we didn't have the data from the Helios B trial. The data just wasn't powered to give us that information. But we're hopeful that these trials will actually give us some insight into that and whether that could be helpful for our patients.
But as of now, we just don't have the data to
support that. And as we'll talk about in a moment, and as we heard, it's it would be $750,000 per year for the healthcare system to put people on both of these therapies. So that decision is not made lightly. So I know that I'm almost out of time, so I'm just going to fly through these last few slides. So for our investigation, our clinical trials that are going on, there's really exciting work in the gene editing space. There's this CRISPR-Cas9 technology, which basically goes in and with one infusion permanently edits out the TTR gene in the Magnitude trial, which is a phase 3 trial that's ongoing. It's called NextZ, or NTLA 2001. The phase 1 data has been published, and we see that there's a 93% decrease in TTR levels that's sustained over 36 months after even just one injection. Unfortunately, the phase 3 trial has been on hold because there were some cases of liver toxicity, but the peripheral neuropathy trials actually just released that hold, and we're hopeful that soon the cardiomyopathy trials will be up and going again with modified inclusion criteria. And then moving on to the fibril depleter degrader therapy. And this is really, in my view, the holy grail. If we could figure this out, if we could get therapies that help to clear out the amyloid fibrils, this is really going to bring us to the next level in treatment for our patients. Because my patients come to me and they don't just, yes, they're appreciative, they want to halt the disease progression, they don't want to get worse, but they want to feel better. We want to reverse the disease state if we can. And so these therapies hopefully will help us to drain the tub, using that analogy from before. And a kind of proof of concept idea was at the National Amyloidosis Center in the UK, a couple years ago, they really didn't have access to disease-modifying therapies outside of clinical trials. And so it was kind of a natural history. They just watched their population. And they actually had 3 patients who had spontaneous resolution of their disease, where when you look at the planar images of the pyrophosphate scan on the right there, after 3 years, the technetium uptake just melted away. It's totally normal by 3 years. So what was special about these 3 patients? Well, they had high titer circulating polyclonal IgG antibodies against the human TTR, which is what we're trying to replicate. And this wasn't present in the other 350 patients, and this just naturally occurred. But so our hope is that with these therapies, we're going to be able to see that same result for our patients. And we have claramitug and coramitug that are being studied in depleter CCM and Cleopatra, and they're given every 4 weeks intravenously, and so we're waiting on those results. Okay, so it's a lot of information, and just to wrap up, it's a lot to digest. But just to summarize, we have 3 FDA-approved therapies as of this month, which is really incredible when you think about the evolution over the past even just 7 years. They all are amazing drugs. They all provide about a 30% relative risk reduction in all-cause mortality and cardiovascular hospitalization. People always ask which one is best. We try to compare the trials side by side, but we just can't because they're different trials. They have different endpoints, different statistical plans, different follow-up, different populations. The more modern trials were, less sick population. But what we do know is that, all 3 of them are tolerated really well. They have minimal side effects. And when you overlay the survival curves from each of these trials, we see, just looking at the placebo arm, which are the curves on the bottom of each of them, our survival is getting better and better, and that's because we're doing a better job at heart failure management. We're diagnosing patients earlier, and the survival curves are really approaching that of age-expected mortality. So we're really turning this condition from a death sentence into just a chronic condition that people can live with. So when I see my patients, I'm very transparent about the data and about the different therapies, and I talk to them. We talk about the differences in administration, 1 pill a day, 2 pills twice a daily, 1 subcutaneous injection every 3 months, although with the caveat that the silencers, you always have to supplement with vitamin A, which is a pill daily. We talk about the cost to the healthcare system. Most patients have been able to get into patient assistant financial programs where they're not paying that much, but we still hear it's a big burden on them. And then just to our healthcare system, and at some point, we don't want to bankrupt our healthcare system, so we need to be stewards of these medications. If I do have a patient with variant cardiomyopathy with peripheral neuropathy, I do oftentimes favor the silencers because we have robust data for that condition. And then this is really a data-free zone. Different providers have different theories about silencers versus stabilizers. If you stabilize, do higher TTR levels really correlate with heart outcomes. We may have some data for acoramidis, but not necessarily for tafamidis yet. So in conclusion, we have multiple novel TTR disease-modifying therapies. The verdict is out on which therapy is best and for which patients. We really need amyloid fibril depleter therapy to supplement those silencing and stabilizer therapies to potentially reverse the disease process to improve rather than just attenuate functional capacity and quality of life. Okay, thank you.
So thank you to our panelists. It's now time for questions, comments, concerns. If you have any, please raise your hand, and Paul and I will go to you with the mic. You guys can share this.
It was a great conversation with all of you guys. My question is more directed towards the heart failure specialists. I'm an interventional cardiologist in the community. I take care of patients as a community cardiologist. My question is, I have some patients with heart failure with reduced TF, 2 or 3 of them who have biopsy proven as well as PYP positive cardiac amyloidosis. I have them on therapy for a couple of years on tafamidis. I just don't see an improvement in the EF. And obviously the other issues with tolerance of guideline-directed medical therapy in these patients, especially the beta blockers. In these patients, in your experience, have you seen any particular heart failure GDMT drug being better than the other to help improve ejection fraction? And do you actually see that in clinical practice?
Yeah, so I think that's the issue right now, which I was pointing out, which is that I would not expect that any of these therapies are going to improve the ejection fraction. I think the fact that the ejection fraction goes lower is a sign of more advanced disease. And again, we don't have therapies to reverse the disease course. And the GDMT for heart failure with reduced ejection fraction doesn't necessarily apply to this population. There have been large propensity matched retrospective trials that looked at the SGLT2 inhibitors and the mineralocorticoid receptor antagonists, and those have really shown very good, promising data for reducing mortality, cardiovascular hospitalizations, improving symptoms, improving diuretic requirement. So those are really my cornerstone treatments for those patients. I'm not as afraid of beta blockers. I think they've gotten kind of a bad rap. I think the goal is that you don't want to beta block people down really low in the way that you would a normal HFrEF patient. I usually actually try to keep their heart rate above 70 if I can, but if they need the beta blocker for AFib management, or if you do want to add it a low dose for their heart failure with reduced ejection fraction and they tolerate it, that's fine. And the idea is that these hearts are so stiff that they can't relax, right? We talked about what is HFpEF. It's that the heart can't relax, and so there's a fixed amount of stroke volume that the heart can push out with every heartbeat, and so they're dependent on the heartbeat to augment their cardiac output. So I try not to use them at really high doses, but you really see every patient is different. But I wouldn't expect them to improve the EF in the way that I would another dilated cardiomyopathy with reduced ejection fraction.
Hi, I kind of know your your answer to this, Dr. Stern, but I wanted the group to hear it because we have a private group on Facebook for our ATTR wild-type patients, and we also have one for our hereditary patients. And we recently put out a survey asking which treatment they're on. And in our wild-type group, 50% were on tafamidis, and 25% of the group were on tafamidis and Amvuttra, both. And in our hereditary group, the majority were on just one drug. So where do you stand on people being on two drugs?
Yeah, no, that's a really hot topic in this field right now. And as I mentioned, we really don't have data to support patients being on two drugs. And if if I had to give a public comment, you would say, there's no data to support this. We really shouldn't be putting anyone on it. But I think we're also, we're all patient advocates too. And when we see our patients getting worse, it's hard to just sit by and not do anything about it and say, well, there's nothing else to try when we do have other therapies that it just like, if you have a patient on a statin and, one of them causes certain side effects, you switch to another one. I think so for me, when I think about combination therapy, I'm not as black and white about it. There are some providers who really are. And then there are some people who are just throwing everyone on it, which I don't think is the right thing to do. But for me, if I have a patient who has really aggressive disease, for instance, in my practice, I just saw a patient this week where they have multiple family members who had heart transplants at a young age and really rapidly progressive peripheral neuropathy, and they have the variant form. I actually, I will sometimes, but very rarely start someone on both therapies. But if they have really aggressive disease, I may do that. But if I see that someone is progressing on a certain therapy, I will either try to switch them to something else or potentially add a second, the stabilizer silencer combination if it's if they're really progressing, but I feel like they're still early enough in the disease course. They're not the stage 3 patients. They're, still maybe stage 2, but have had a significant decline. And particularly if they have peripheral neuropathy. And even in the wild type patients, there's some newer data and more data that maybe it's helpful in that population too for their neuropathy symptoms.
Can I answer?
Yeah.
So I'm on vutrisiran, but I kind of am on combo because I also take the fluticasone off label.
Yeah.
So a lot of times that combination is used as well.
Yeah, so I didn't talk about diflunisal because it hasn't been studied in phase 3 trials, but it's a non-steroidal anti-inflammatory medication that was actually initially shown to stabilize TTR, but there have been concerns about its use due to it being a non-steroidal anti-inflammatory, like ibuprofen, or which we usually caution against in cardiac and renal disease, which oftentimes our patients have. And there are some providers across the country that don't really use it, but there are some who say, it's such a low dose that it really, and I'm sure you've been on it for quite some time. Yeah, and people do fine and they do well on it. And so I also have patients where they don't technically meet the inclusion criteria. For instance, if they just have wild type in their carpal tunnel or their spinal ligament, but they don't have it in their heart, we don't have an indication to treat those patients yet. But those are the ones we actually want to treat, because those we want to prevent progression to having cardiac symptoms and cardiac involvement, or maybe they're really impaired by their non-cardiac symptoms, and that may be someone that you can use diflunisal in. But again, it's off-label. We don't have phase 3 trials looking at that drug.
So I want to give you guys a break. So this is going to be our last comment or question for now. Sorry, the speakers will be here for later.
I'm a patient, so some of the terminology is a little bit difficult. When you're talking about acromitis, that's a trophy, I presume, right?
Yes.
Okay. Secondly, some of your overheads are pretty interesting, but is there any way to get a copy of any of those or not?
The slides, you mean? Or
Pardon? Yeah, the slides.
Yeah, I think that Dr. Dev and I were talking about that last night. I think we'll be able to provide slides, yeah.
And then finally, I was under the impression that stabilizers were replacing silencers pretty much. Am I off base in thinking that way?
Yeah, no, I think they're all, as of now, stabilizers and silencers are just different ways of treating a similar problem. And it's not that we don't know that one is better than the other. They're all great treatments. So my take-home message is that we need to diagnose patients earlier and then just get them on any form of treatment. And I think that the future is looking very promising for this condition.
Questions that you have about treatments and the alternate names, and we do have a sheet we'll pass out.
We can't hear you, ma'am.
What?
What you said is that this afternoon in the breakout session, Dr. Stern will be there, and they'll talk about treatments, and they have sheets that have the different names of the drugs. So you really would want to make sure that you attend that session. It's in the breakout session. It's on the calendar there. So these questions will be addressed. And I would just like to reiterate that this is just a sample of what you'll have for the rest of today. And this has been fantastic so far. I'd like to thank our panelists here.
Thank you for sharing your knowledge. And thank you to our attendees for your engagement. Please don't forget to visit our exhibitors hall over there. We're giving you 15 minutes. So 10:05, please be back either here for the neuropathic and genetic evaluation of transthyretin amyloid, or in the auditorium for tissue is the issue. Thank you.
I just got a cardiogenic shock.
Oh, no. Yes.
Yes, please.
Okay, great.